staying well, staying safe. We'd like to remind you that the Facial Pain Association is open, although remotely, for business. So please give us a call. You can email us. We are going to continue to provide programs and information and support. Some of our methods have changed for the time being, and we are thrilled to be offering these Facebook Live events. The next Facebook Live will be on Tuesday, May 5th at 7 p.m. We have two members of the Facial Pain Association Board of Directors who will talk about their experience with medical marijuana. We will continue to hold webinars and send you a bi-weekly email bulletin with important updates about programs and information on neuropathic face pain. If you are not receiving these, please email info@tna-support.org and ask to be added to our email list. Tuesday, May 5th, the day that we are having the next Facebook Live, is also Giving Tuesday Now, which is a global day of unity to take place on May 5th as a response to the unprecedented need caused by COVID-19. We hope you will consider making a gift to the Facial Pain Association on May 5th. You make it possible for us to continue to offer programs such as these. I would like to now introduce Dr. Julie Polizzis. She is going to be doing a wonderful presentation on diagnosis, and we're going to follow that with questions and answers. You are able to type your questions, and I will be talking with Dr. Polizzis after her presentation and presenting her with some of those questions. So Dr. Polizzis,
Thanks so much, Allison. Thanks everybody for joining us this evening. I'm thrilled to be here. I'm a neurosurgeon. I practice in Albany, New York. I'm also chair of a research department, the Department of Neuroscience and Experimental Therapeutics. So I wear two hats often. And today we want to talk a little bit about diagnosis and common issues that come up. We're going to keep this a little bit high level with some advice, and then we can delve a little bit more into the nitty gritty with some of those questions. Next slide, please. These are my disclosures. These are people I work with or get grant support from. None of them really pertain to what we're talking about today. I hesitated a little bit because, if we talk into some of the treatment options, some of the devices that I implant are made by these manufacturers. Also another disclosure is that's off-label use of those devices. Next slide, please. So what is face pain? It's really interesting because, oftentimes as a neurosurgeon that specializes in functional neurosurgery, which is what my fellowship was in, and that's neurosurgery aimed at improving quality of life. People send me patients and they say they have trigeminal neuralgia. So oftentimes the doctor or the provider that is sending somebody to see me has labeled them with a diagnosis that they may or may not have. And so then I spend a lot of time walking back and determining whether this is truly trigeminal neuralgia or if it's something else going on. But it's kind of, when anybody hears about face pain, as a provider, just because we get so little experience with pain in our training, they think it's trigeminal neuralgia. So that's just a little tidbit to keep in mind as you talk to different people. When you're talking about pain, it's also a really interesting sign or symptom as opposed to other things. So if you have hypertension, you have high blood pressure, and you go to the doctor and you get your blood pressure checked and it meets a certain parameter. Pain is very subjective. If people have it, there's differences between how different people feel pain. And some of those are due to body mechanics. Think of the differences in women in labor and how some people have more or less pain. Or, think about your own issues. If you've had something where you've broken a bone and it hurt one time more than it hurt the other time. Some of those are anatomical, and some kind of depend on what's going on with a number of things in terms of processing emotionally and cognitively where you're at. And, for those of you in pain, I know that when you're tired or when you have a lot of life stressors, things can sometimes seem worse. And in fact, this is commonly understood that the pain pathways are really complicated in the brain and coordinate between that sensation as well as how we process that sensation. And that's all part of the pain process. And this is really happening, and it's really physiologic, and it's not in your head. These are all components of pain, and they're equally as important, and we have to treat all those. Next slide, please. So another reason why facial pain is really difficult to diagnose is because sometimes symptoms overlap. So, during this coronavirus epidemic, webinars and things like this are becoming exceedingly popular for both patients as well as providers. So I was actually on a webinar last night and learned something about migraines. So migraine patients, 70% of people can have neck pain. So imagine that, that's something that you never really think about. And when you're talking about facial pain, it can come in all shapes and sizes. I see people with face pain who in fact have migraines. So look at that third image where you see the whole side of the face. That's illustrated in red. That's meaning the painful area. That's a type of migraine. Then when you have pain just around the eye like that, that's a cluster headache. And, that can be hard to differentiate between trigeminal neuralgia because, if you think about the distributions of the trigeminal nerve, that's in one of the distributions. Then we have, tension headache, or the headaches that occur when, you're need glasses and aren't using them, or other types of things. And so there's a lot of mimickers. TMJ is really common. It oftentimes those people spend a lot of time at the dentist as well. And we know that there's that correlation between dental work and trigeminal neuralgia. So sometimes TMJ can be difficult to diagnose. And then, sinusitis can do a lot of different things. Post-herpetic neuralgia, that involves the trigeminal nerve. And so that gets a little bit more into the next slide, which I'll go through in terms of diagnosis. So next slide, please. Well, maybe it's not the next slide, but we will talk about it. So how do you find an accurate diagnosis? This is tough. And, there's a famous physician that once said that 90% of a diagnosis can be done with a history, and the other, 10%, is split between the physical exam and diagnostic exams. And I think that's a very true statement. So your doctor needs to spend time with you in terms of finding out what your pain is like. And that's why we spend a lot of time asking, people to describe their pain. And, I know right now we're not supposed to touch our faces, so I'll just put my finger kind of in front of my face. But, I will ask people, I'll say, where does your face hurt? And they'll go, oh, all over here. And, so in fact, I will ask people to use one finger to point so I can nail down exactly where that pain is. And, that helps me. And sometimes it's, kind of the way you ask the question or the way you think about it, because sometimes when you're in a lot of pain, your whole side of your face can hurt, but really, you might have something in this second distribution, which is the one over the cheek. This one's the first one, and this is the third distribution. So you have to keep in mind, when your pain starts, where does it start? And I think that's a key question to ask. That location is really instrumental. Triggers. What causes your pain? Touching your face, the wind touching your face, that's a really good sign to me that somebody has trigeminal neuralgia. Often with brushing your teeth and not being associated with any dental type things. Dental things don't tend to be associated with brushing your teeth unless you're doing it super vigorously. So those are two big questions that kind of impact what I'm thinking. And then I also want to hear, from somebody that I'm going to diagnose with trigeminal neuralgia, that it's this acute stabbing, shocking pain that happens for like 10 seconds and then it stops, because that helps me to make the diagnosis. There can, of course, be constant pain, but trying to whittle down what the symptoms are and what the component of that traditional trigeminal neuralgia are is really important to making a diagnosis. Next slide, please. So this was the slide I was alluding to in terms of types of facial pain. So the kind of the easiest trigeminal neuralgia to diagnose is that traditional type 1, typical, any of the words that, this is what the textbook, if your body read the textbook, this is what you would have if you had trigeminal neuralgia. We know, of course, our bodies don't read the textbook, so we have to keep that in mind. But trigeminal neuralgia type 1, it's in one or more of these distributions, often not 3, sometimes it can be, but, and by 3, I mean often not all 3, it can be in V2 and V3 or V1 and V2. And it's that, gosh, the wind hits my face and I have that piercing, acute, stabbing, intermittent pain where I have periods where it goes away. And then historically, people will tell you too, because sometimes this happens in older people, right? And so, they've done things over the years and they'll say, okay, you know what? I had this kind of happen to me 10 years ago. It happened really bad for, a month and then it went away. And that's also pretty typical of the history. So trigeminal neuralgia type 2, and sometimes people call this atypical. I think this is still in the world of things people, providers should know, but it is confusing. There's a constant component to the pain. So you're going to have all those symptoms that you have with trigeminal neuralgia type 1 most of the time, in the majority of cases, with that background of constant pain. So I'll spend more time figuring out about those intermittent shocks than I will about the constant pain, because that's helping me make the diagnosis. And, I think that we're going to talk in the next slides about what you can do to be helpful to your provider so that you can get the right diagnosis. Sometimes your provider needs to be redirected. That happens. It happens to me when I go to the doctor or the PA or NP. But sometimes they're going down a certain direction, and are trying to get information in there. And so let them ask their questions if they're like a woman on a mission, as I often am when I'm nailing down these type of things. So trigeminal. I'm going to skip to trigeminal deafferentation pain, because that's a little bit easier. So deafferentation pain is typically anesthesia dolorosa is the other word you're going to hear for that. And so this typically happens after somebody has already had a diagnosis of trigeminal neuralgia. They've had multiple treatments which have changed the way the nerve fire. And now, rather than having, their original symptoms, they have profound numbness and profound pain. And, it's in the setting of this history of multiple procedures where things have gotten worse over time or after one procedure in particular. So in those cases, I'm going to spend a little bit more time nailing down the history of what's been done for this, and when things happened. And I know sometimes it's really hard as to identify when things had happened in the temporal and causal relationships, meaning like, did it happen before or after something? But that's where I spend time there. So I skipped trigeminal neuropathic pain because that and trigeminal deafferentation pain can be the same thing, but trigeminal neuropathic pain can be kind of an intermediary step between trigeminal neuralgia and trigeminal deafferentation pain. It can also be its own entity. Anytime you have surgery, there is an injury that goes on to the nerve. Anytime you have surgery on that nerve, there's an injury. Even when we're trying to fix it, we've touched it, we haven't left it how it was, it predisposes you to have neuropathic pain. There's some schools of thought that people that have chronic pain have a component of neuropathic pain anyway, because of the way that change in plasticity occurs in the brain. So, that's always kind of in the back of my mind. And I kind of, when I'm making my diagnosis, nail down between those trigeminal neuralgia type 1, type 2, deafferentation pain. And this is kind of my fourth diagnosis here after I've ruled out those other three. That's how I end up there. And I think that's probably the best description. And this isn't something that's easy to teach. Most things, I love to educate students and fellows and residents, and I generally think I'm pretty confident at it. This diagnosis is really a tough one, and so this is probably like the best guidance I can give to people. Symptomatic trigeminal neuralgia, that's, in my opinion, just another word for any of these that kind of hurt. I do differentiate between neuropathic pain and neuralgia pain. Post-herpetic neuralgia, so, it gets a little bit tricky because for post-herpetic neuralgia, that's not going to respond the same way as trigeminal neuralgia. So you're going to remember that you've had shingles in the area. And so you're going to have, when you get shingles, it's often in one nerve distribution, and that can be on your chest, that can be on your abdomen, it can be on your face. So it can be any of those things. Atypical facial pain. So people use this word and it can get very confusing to know exactly what they're talking about. And, I think if somebody gives you that diagnosis, I would ask them what they mean and or if to tell you why they think it's atypical. Because I think it can be a catch-all term, and that word doesn't help me decide what to do. The reason why diagnosis is so important on this slide or in face pain in general is because the options are very different. Sometimes when people have back pain, or I'm going to do similar things regardless of what the cause of their back pain is. So it doesn't matter as much. Here, I spend a lot of time trying to get the right diagnosis. I've thrown occipital neuralgia up on the slide. So the occipital nerve is in the back of the head. And so, obviously that's not the face, but the occipital nerve is actually the greater and lesser occipital nerve. And it can actually innervate all the way almost, not quite to V1, but it can be a mimicker. And again, when you have that, when you have pain and it's like just killing you, it can radiate anywhere. And the reason it radiates is it can be a lot of different things. But think about what you do when you're in pain. If my arm hurts, I grab it and I hold it, and then I'm probably like being careful not to bump it into things, and I'm guarding. And so that's tensing up my neck and my back. And so it's not so uncommon that people that have one pain syndrome have another, because they're compensating for it in different ways. Next slide, please. So, again, now we're on to the, we've spent 90% of our time, like we're going to spend in this lecture, on history, because for me, that's the crux of this. But there are physical exam findings. So I'm going to check your face and see how you feel sensation. I always say, you go to the doctor, you tell us it hurts. So that's the first thing we do is touch that area. Hopefully, somebody pauses before they just come at you with touching that area. I'm going to check how strong your jaw is. So I have people bite down in class just to see if there's any weakness there. And then I'm going to check other aspects, of your nerves to the head, your cranial nerves, to make sure there's nothing else going on that could be a mimicker of this condition. Next slide, please. So a diagnostic imaging, MRI is used in these cases. And so one of the common things that happens is somebody goes to their primary care doc and they get an MRI because they know that trigeminal neuralgia is often caused by a nerve compressed by a vessel. And so they're looking for that. Unfortunately, what happens is they don't get the thin enough slices through that area. And, oftentimes insurance won't approve it anyway without going to a specialist. So that's why we send you back and get another image, and we want special sequences as well. And sometimes that happens automatically, but not a lot. So that's one thing we want to look at. And then, we always have to put that into context. So again, let's go back to the back pain analogy. So I see a lot of people that have all sorts of pain symptoms. And there's actually been studies done on people that have back pain and don't have back pain, and they all got MRIs. And you know what? They have the same number of findings on their MRI. So just because you have a finding on your MRI doesn't mean that's what's causing you pain. And it's up to you giving this history and, your doctor evaluating to determine what the exact correlate is there and putting it in perspective. Whenever you get any imaging finding, it's a radiologist's job to tell you absolutely everything that's not perfect on your MRI. And so we all feel like we're falling apart and we don't know what to do with some of that information. Again, you have to have somebody that is used to looking at these films to say, hey, that's something, or hey, that's nothing. And you go from there. CAT scan I use in very rare cases, and for different reasons. So, I'll use a CAT scan if I'm worried about any bone compressing on that area. I'll use a CAT scan if I'm going to do any sort of surgery that depends on getting in the exact right spot. But most of the time for trigeminal neuralgia, this is an MRI. Next slide, please. Sometimes we'll use diagnostic blocks. This isn't a mandatory thing in TN or in any of the mimickers of this. The only time I might try that is for an occipital nerve block to rule out occipital neuralgia, if that was my other differential. What we block here for trigeminal neuralgia can be the sphenopalatine ganglion. Fortunately or unfortunately, that also can treat migraines. So it depends, on what diagnosis what I'm trying to do with that block. If I'm trying to give a treatment, that's one thing. If I'm trying to fine tune my diagnosis, you have to think what you're trying to exclude or include and use this appropriately. Next slide, please. So, again, this is based on history, most common in adults over 50. It's that shocking one side. It's generally one side. It can be both sides, but if it's both sides, I look for something else going on. And again, brushing your teeth, that feeling of wind on your face, these are all things. Next slide. How can you get yourself an accurate diagnosis? Well, I think in terms of this, you have to make it very clear to your provider how much this bothers you. People go to the doctor for very different reasons, and you may go to, the doctor a lot more frequently or a lot less frequently than I, as your provider, go to the doctor. And so sometimes, especially with pain, people don't understand. And this isn't the time to be stoic. We have that happening where, somebody's not telling us how much this hurts, and we have the positive spouse sign where the spouse is actually telling us how much this hurts the person because they're so miserable. So be honest. Does this affect your daily life? Does this affect your sleep? Can you not eat? I need to know how bad this is because that's going to affect my treatment. When you're dealing with a pain diagnosis, it's very common, and any neurologic diagnosis for that matter, to be misdiagnosed at first. There's a lot of mimickers. People have different levels of experience in doing this, and I know it's very, very frustrating. I know it is. I think that's why over time, things like the Facial Pain Association can be super helpful to help advocate for people. Next slide, please. Google is really a scary thing. So you can Google anything and you can find any answer that you want to find. And so you have to be really careful what information you look for. And so that's another great thing about this association where you can rely on the information that is given. So be careful in terms of how you use this. Literally, you can find anything. Somebody's had something happen and somebody's going to say something online that may or may not be accurate. And then I think it's also really important that, it's I very often hear people say, oh my gosh, she had the exact same thing I did, and you did this, or, this happened. And no two people are the same, and all situations are different. So, your best marker of how you're going to do isn't how your friend did or how your mother or brother did. It's how you've done yourself. So, keep that in mind as you're moving through the process. Next slide, please. So after you get an accurate diagnosis, and again, the reason why this is really important in these cases is because the diagnosis depends on what the next step is, and there's very different things that are done for each of these. And you're going to have a series of talks, looking at what these are in terms of medications, injections, surgical treatments. So, we can delve into that a little bit as the night goes on, but you will have some more talks on that matter as well. Next slide, please. So thank you very much for your time and attention. And it was my pleasure to be here, and I'm thrilled to take whatever questions you have. Thanks.
Okay. Thank you so much. Can you hear me okay?
I can.
Okay, wonderful. I couldn't see the questions coming in while I was managing the slides. I'm trying to walk and chew gum, but I'm going to look and just real quickly see what questions came in. I have my list of questions that I had before, and then I was writing questions down furiously as you were talking. I think what came clear to me, or actually really just reinforced my understanding, is that this is tricky. It's tricky for the person with the facial pain. It's tricky sometimes for providers. And I think it seems like it's very important that people are communicating clearly with their doctors, and are advocating for themselves, and are making sure they're conveying their information, but that they're also, being able to identify the correct providers to start. So one of my first questions, I'm going to, and then I'm going to read through these while you're kind of answering, is, excuse me, if someone's experiencing facial pain, at what point do they go to their general practitioner, or they kind of go, this seems like this is really wrong, and kind of jump the line a little bit and insist on seeing an X provider or specialist? And what type of specialist would that be?
Yeah, so, that can... Again, all patients aren't created the same. So a little bit depends on what your symptoms are. So let's say that we're dealing with somebody that has this textbook trigeminal neuralgia. And so if you're having kind of these textbook symptoms, you're going to go to your primary care doc, and you're going to talk about it and figure out what their comfort level is. And so what do you really want at that point? Well, you probably want to make sure your pain goes away. And so, the starting drug for this is carbamazepine. And so that's what most people will use. And, there's some variants. Sometimes people will use Gabapentin or a couple other agents. But is your doctor comfortable in prescribing that? And is your doctor comfortable in getting that up to the levels where that needs to be? And so I think that's a very good starting point. Sometimes your doctor is, sometimes your doctor isn't. If they're not, now's the time to go to a specialist.
So the carbamazepine is sort of the first line of, we'll give you this, and if the carbamazepine touches the pain, then what does that mean?
Yeah. So, I think that, so carbamazepine is typically dosed, anything we do in neurologic disease and any medication, we go low and slow, right? So we're trying to help your pain, but we're also trying not to give you any side effects. And so we want to start at 100 once a day, and then we can go up, and, the highest we'll ever really go is somewhere between 400 and 800. We're going to increase that gradually, and we're going to see if your pain stops. If your pain stops, you're good. And what I tell people at that point is, they say, well, I don't want to be on medication forever. Let's give this, depending on, how long the symptoms took to develop, between 3 and 6 months, let's leave you on these doses. With carbamazepine, you have to get some blood work done every once in a while. And then after that, we're going to wean you down and see how you do. And you're just fine at that point. If, it's not working, then I think you have to move on to the next step.
Okay. If someone presents with pain on both sides of the face, what other diagnoses or what will that indicate to you?
Yeah. So, I think that we always use the word pathomnemonic in medicine. And so what that means is, oh my gosh, I hear some words like, how I hear, oh, the wind is irritating my face on my cheek. I think trigeminal neuralgia. I get worried when I hear about bilateral pain that something else is going on, like multiple sclerosis. And that's not to say you have it, and try not to get upset and jump ahead. But in that case, that's a little bit atypical and that's a little bit tricky. So in that case, I would go to ask for a neurology referral sooner rather than later.
Okay. If that is ruled out and someone has pain bilaterally, is there a more common neuropathic facial pain diagnosis, more so one than the other, or can it still be that whole page that you have? It could be any of those still.
It could be any of those. Again, you're not typically going to get the deafferentation pain if you haven't had any surgery. You can have some dental work type things that could also cause some components of neuropathic and deafferentation. But say you've never had, you go to the dentist for your cleaning and you have no other health problems, you're staying in the neuralgia type things, the trigeminal neuralgia 1 and 2, and not getting into that other diagnosis at that point.
One question is, how do you diagnose occipital? Is it occipital neuralgia? Is that diagnose that?
So, again, this is a lot based on history. And so that can look different, because people have neck pain, right? So, when you're thinking about the occipital nerve, it's in the back of the skull. So I don't want to induce pain in anybody, but if you were to check this on your own, there's a little bit of a notch on the back of your head. And, you can just move your finger on the back of your skull and you'll know when you get it, right? And that's that area. And so that's where that nerve is. And so, I can send people jumping off the table when I push on that. Then the nerve radiates up the back of the head like this. And so what I'll do in those cases is, that nerve is really nice and easy to block. And so I'll do a block in that area and see if people respond. And sometimes that block actually can work for 3 to 6 months.
Okay, so again, these are some things that you can test and see, and if the treatment touches the pain, then that also helps you understand what is going on to begin with.
Exactly.
When a patient comes to an appointment with you, first time that you're seeing them, what can they do to be prepared to help you reach that diagnosis? I wrote down, you were saying that 90% of a diagnosis is from history. I think you were quoting someone else, but you said that you adhere to that as well. And so that made me go, wow. So that's really, really important, again, that a patient is communicating, but also the question, I believe, is also what should they, in practical sense, prepare to give you or to tell you? Should they be creating a pain diary? What should they be doing so they can best help you reach the diagnosis?
Yeah. So I think a pain diary can be helpful for a patient, a little bit more so in some ways than it's helpful for a doctor, but I think it helps the patient get the doctor the information he or she needs to know. So if you write down, when your pain, I'm really interested about when your pain starts. And I'm interested there because you're going to be able to nail down the location, and I'm going to know what it feels like before everything goes haywire and your whole body kind of hurts. So that's the information that I want to know. I want to know the other things and what happens in the aftermath, but in terms of making the diagnosis, that's the part. What were you doing? Where does it hurt on the face? What does it feel like? How long does it last? Those type of questions are really important. And so then if you had your pain diary, you've written that down, what I want you to kind of do is I want you to take notes on your pain diary to summarize that into okay, this is as objective of data as I can give you. And so I think that's the first step. Then the second step, that we touched upon a little bit later is I need to know how bad this is. What is this preventing you from doing? If you can't get out of bed, if you can't eat, that is far different than, oh, it happens every once in a while. I just go about my business and it's fine. It goes away in, 15 seconds. I'm going to do different things.
I think that last point that you made, I think if possible, people have someone come with them who know them really well. Because I know sometimes people downplay, for whatever reason, or they're just very, they endure pain really well, but the people who live with them or, know them very well can say, I've noticed a change, or I've seen you do this, or kind of call them out on something. So how important do you feel that it is, or how beneficial rather, for someone to, if they can, to bring someone with them who kind of has been seeing what's going on with them?
I think it's great every time you go to the doctor for, like when you go for a physical or, routine care, I don't think you need to bring anybody. But when you're going to a doctor about something that is seriously affecting you, that's abnormal or wrong or new, I think it's great to have another set of ears there. One, to help advocate for you, just as you're saying, and to keep you honest and to make sure that you're telling the doctor everything he or she needs to know. And two, as a surgeon, I know what happens to patients when I say you need surgery. Everything shuts down. You don't hear anything else that I say. And so you need that person taking notes next to you to remind you, oh, she said this, or she didn't say this, or, at least to have, somebody there that you can bounce what I said or how you interpret it and come up with your list of questions back for me.
Yeah, absolutely. I got a few questions here about migraine. I think somebody asked about whether it's usually unilateral. Someone asked, can it be on both sides? So can you just give us a quick, how often is migraine misdiagnosed for trigeminal neuralgia or vice versa? And is there a tip, like migraine is usually this and TN is usually this? What's the deal? One more time.
Yeah. So, I think it's... migraine is like a great mimicker. And, so what I mean there is it can do so many things. So, how many times have you've heard crazy stories where people get diagnosed with like the ocular migraines where you can't see or have moments of vision loss where you just go, oh, I didn't even know a migraine could do that. I've seen other people that have like sensory changes throughout their body when they have a migraine.
Yeah.
And so migraines can do so many things. So again, I think for trigeminal neuralgia type 1, the diagnosis can be pretty straightforward. When you start getting into these other things, I'm going to delve a little bit deeper into what you're doing, especially with constant head pain, not that sharp shooting. Migraines don't tend to be that sharp shooting. I mean, they can do anything. But I'm trying to differentiate the two. I wish I could say, oh, this is definitely one or the other, but it gets a little bit dicey after the TN type 1.
And in terms of medication, somebody is asking, is there one kind of medication that will help both trigeminal neuralgia and migraines?
Gosh, we should be so lucky, right? So, I think different migraines respond to different things. So, the gold standard of migraine is sumatriptan, which is that Imitrex. And now we've had some exciting developments in the CRGP agonists, which have happened over the last couple of years. So those are typically migraine treatments. That's different than trigeminal neuralgia type treatments where, we're looking at Tegretol, we're looking at Gabapentin, we're looking at neuropathic agents. So generally those are two different things. I do love it when something works for both things. And, so over time, once we've narrowed down the diagnosis and we've got you to a good spot, we can start playing a little bit to see if there's something that works for both. But as a starting point, unfortunately not.
Okay. And I had this question. I'm going to just jump back to this really quick. You talk about you want to know what's going on when the pain starts. Why would pain come and go? And what does it mean when someone has pain coming and going over the course of weeks or months or years? First of all, I don't know if there's a simple, why would pain come and go? And what does that mean to you when someone, either has constant pain or pain that's intermittent?
So, I think great question, complicated answer. So when you're living
I tend to
with,
ask those.
yeah. So there's so many things that can happen. Okay, so again, let me say I have pain in my index finger. So I can have a problem anywhere from my index finger up my arm into my, my plexus, which is the nerve things here, into my neck, into my brain stem, into my brain, that's causing me to have pain in that finger. And with trigeminal neuralgia, though, we typically talk about, the dorsal root entry zone, which is where the trigeminal nerve goes into the brain stem, as, the area we treat. The pain can be generated from a number of different spots. And the longer you have the pain, the more the brain is involved in terms of managing what goes on. So, the longer things happen, the more likely kind of you are to have that constant pain develop. Then, again, all those parts can be involved. And, so one thing that happens in chronic pain is the ganglion, which is another big area in the trigeminal nerve. When we talk about doing the balloon compressions or the radio frequency, we're targeting that ganglion. Ganglions they change when you're in pain. They change what they're made of, and what type of channels they have, and what the inflammatory cells look like. And that being off balance causes sporadic firing. And so that's what causes kind of the intermittent abnormality. And then when things get fixed, that can settle down, that aberrant firing.
Is trigeminal neuralgia degenerative, or is it more what you were saying, that your brain kind of is like a snowball effect in terms of your brain's reaction to the pain coming back?
Yeah. So it's generally, I think it happens to occur more often in elderly people. So there's something that goes on over time where maybe your nerves don't fire quite as perfectly as they did before, kind of like the rest of us, that gets a little bit saggy as time goes on. Having said that, I think generally this is an abnormality from the brain, and especially with chronic pain, it involves all those processes.
Okay. Are you familiar with the term central pain? And can you just quickly give us is that another term for one of the diagnoses you already mentioned?
Yeah, no, so it's kind of its own. And so central pain actually is something that we generally use as a word when the pain comes from the brain itself, or from something that has happened in the brain. So the textbook thing that happens here is somebody has a stroke and they have pain afterwards, and that can be in the trigeminal distribution. It can be in the whole side of the body. It can be a variety of different things, but it's usually related to somebody having had a stroke. And again, it can be other things too. So if somebody says, "Oh, you have central pain," don't be like, "Oh my God, I have stroke. I have to go out and do all these things." But that is the most typical reason why people have it. And, that's even trickier, because should that not respond to medications, what our treatments get even different than the ones that we typically use.
Okay. And the neck and shoulder and back pain, I'm trying to think what my question about that is. It's definitely something that I see a lot of people posting on social media about and talking about with each other. And how does that factor into you giving the diagnosis?
Yeah. So again, I think it gets back. So, obviously you're like, your body didn't read the textbook, so we have to work through that. But, I think that's why I want to narrow down when the pain starts, where does it hurt? Because the pain, after you're in pain, it's more common that it can spread to different locations. Now, why does that happen? A couple of different reasons. One, again, you're holding your body in an abnormal position. So, think about when you sleep funny on your arm or whatever, and you wake up and your hand's asleep. It's the same type thing. You can have responses like that. The other thing that can happen is that where the nerves go and the nuclei for the trigeminal nerve, it's right next to some of those nerves that innervate this area, and thus there can be some cross-talking.
Okay. I'm getting an echo of my own voice. I don't want to hear my own voice.
I hate it when that happens, but you're good.
Good. You mentioned age and that you see this more frequently in people who are older. So for someone who is young, how either what would you advise, or what do you think the concerns are for someone who's young, who's experiencing facial pain, and making sure that they get a diagnosis?
Yes, so I think that this is harder for doctors, and it's harder for those patients in some ways. It's just very much like thinking about, the difference between men and women and heart attacks, right? So men have this stereotypic type heart attack symptoms. Women don't tend to have them, so they're often misdiagnosed. And so I worry about younger patients having the same issue, because there's, again, we have to go through so many diagnoses. We have to somehow prioritize those. So in our mind, we go, okay, here's our algorithm. And, if you're 30 and you're not 70 and you have this, how could it be trigeminal neuralgia? So I think finding a doctor that listens to you, and I also do think that, you have to make sure common things happen commonly. So it's much more common for a 30-year-old, say, woman in this instance, to have migraines than it is to have trigeminal neuralgia. So that diagnosis, I'm going to spend a little bit more time including or excluding it, just because that's the common thing that happens. But again, it's really important. We all have gone to providers that hear us, and we've all gone to providers that don't hear us. And when you're dealing with chronic pain of any time, of any of these types, it's really important to go to a provider that hears you.
Yeah, I agree with that. I think it's great for people to get, multiple opinions, if possible, and to definitely, like you said, to make sure that they're reading, the correct information, and so they can educate themselves, so that when they go to the doctor, they can again communicate clearly, but also kind of have some understanding. And I think that's really important. Can we go back to post-herpetic neuralgia? I've learned all of these really big words since I've started with the Facial Pain Association. Post-herpetic neuralgia, is it only caused by something from shingles, or can it come from another strain of herpes? Like, some people get cold sores or things like that.
Yeah. So, yes, I think any of the post-viral neuralgias can come from a multitude of different things. Having said that, again, we're going with the common things occur commonly. And so most of the people, maybe it's my own bias, that I've diagnosed with post-herpetic neuralgia have had something where they describe some sort of breakout or flare-up, or have had shingles. And, even if you haven't had shingles in that area, that's an important fact to bring up to your doctor anyway, just because, it's in your system, and so maybe you didn't appreciate it. And then I think that is another good fact that you bring up there too, to say, okay, I suffer with, because some people get cold sores way more than others, right? So, if you're one of those people, I think that's a pertinent, we call them pertinent positives and pertinent negatives, like these important details one way or another that you should give to your provider. And I think that's one.
That actually made me think about the coronavirus, because I read an article this morning that a new symptom that's been identified is that people are having skin changes, and there's something called corona or COVID toes or something, where some people are presenting with their skin, discolored or on their toes or on different parts of their body. So when we talk about the viruses, well, the coronavirus, is there anything, I know I'm getting a little bit off a topic with diagnosis, but what can you tell our viewers about anything either they can do proactively or anything they should keep an eye out in terms of the coronavirus and their neuropathic facial nerves?
Yeah. So, I think in particular, I think a couple of things. So, again, when we're talking about people that suffer from facial pain, we're generally talking about people that are at risk, meaning older than 65. And so, we have to keep in mind that we want to do all the things about social distancing, wearing our mask, not touching our face, as opposed to me 5 million times during this talk, and and doing those type of things. Having said that too, when people, don't fall in that demographic and have facial pain, meaning you're younger or, anything here. I'm a big believer that living in chronic pain causes your body to live in a state of stress. And so I think that predisposes you to a lot of different things. And you can be, especially, like when I'm stressed out, I'm much more apt to get sick. And I think everybody kind of has that experience. And then, I get it worse than I may already have had it. So making sure that you're just keep taking your medications, keep doing everything you can do to optimize this. This is living with a chronic disease, the same way you would live with diabetes or blood pressure. Keep taking your meds and keep being proactive, because that will keep you healthy and, is important for your own self-care.
Yeah, and I think that there's a big emotional, mental component, not only to us being, isolated because of the coronavirus, but, most people that I read about and I've met through the Facial Pain Association, it's really important for them to take care of their, their mental health and check in with themselves, with their, how they're doing. And I think it's been more challenging for this community, for sure.
I think that is actually, a great point and something I'm really big about. So, I mentioned that I'm the chair of the Department of Neuroscience. So I have about 60 people that report to me. And so one of the things that we spend a lot of time about is, taking care of your mental health during this time. And, so I think there's things you can do, right? So we might be physically distanced, but we don't have to be spiritually distanced, to quote Governor Cuomo. So, I think that's one thing. There's also a variety of different options that have popped up because of this. Make sure you're working with your therapist. If they have telehealth hours, that's a thing. If you don't have a therapist and you go, gosh, at this point, it's okay. It doesn't mean that you're going to have depression, and it just means that you have a situation going on. There's Talkspace, which is an app where you can find a therapist and or talk to somebody. I'm a big fan of Headspace, which is the meditation app too. And, they were offering a deal where you could get the first 30 days free, where it just helps you kind of deal with different things. And then Mind and Body app is another app on my phone. I'm very into wellness and mindfulness and meditation, where you can take Zoom classes all over the world right now. So, I live in New York, but I've been taking classes in California all week, and you can take them in London. And so it's really fun, and they have meditation, and a lot of those are free.
I would love to post a list of some of those. And I didn't put up your last slide. I apologize, but that had your name and contact information as well. So if that's okay, we can put that up on the Facebook page later, and then maybe we can add some of those. I remember you mentioned some of those in San Diego as well. And I don't know that I wrote them down. I was like, oh man, I got to find out what some of those were. Headspace, I think you mentioned. I think we can all use those kinds of things, but I think those would be great for us to post for folks. Let's see, I just want to make sure, see if I missed any other questions. We have a couple more minutes, everyone. If anyone wants to post another question, we can see if we can get to it. Oh man, I mean, I had so many different questions, but you mentioned triggers. and this might be a very specific question to kind of end with, but you mentioned triggers and you talked about brushing the teeth. And my very specific question is that because when you brush your teeth, it's pulling on your cheek, or is it because really of the nerves in your gums and in your teeth?
That's a great question, and I'm not sure that anybody really knows. I think probably, and and then is it just the whole face, right? Because you think about the other triggers in terms of chewing or on the face, the nerves are so intertwined. So I think it's just anything you're feeling sensation that would normally not hurt, and it's hurting. So I think it's probably yes, both of the above, and it's just anything irritating that area.
Okay. And then another question, is trigeminal neuralgia more common in women?
So, I think that I've seen I've seen mixed numbers on this, but it tends, it tends to be. And, I think the other issue that we always have to keep in mind is how often people use their doctor. So women tend to go to the doctor more than men. So that's something else to keep in mind. And women actually feel pain differently than men on a number of levels and for a number of different reasons. So you've hit another one of my topics that I'm really passionate about. So women actually feel pain more than men do, which is, we always joke a little bit, the opposite of what you might expect. And, there's also different reasons. So there's been work showing that the immune signaling is different between men and women. And so over time, our hope is as we get better and more discoveries in people, that everybody's going to have kind of individualized care. And they're very well for pain, maybe different care for men and different care for women because our bodies process pain differently.
So it sounds like there need to be some studies funded on women only or men only,
Exactly, or powered by, powered in order to, look at that reliably.
Yeah. All right. We have a bunch of questions that are popping in here. I had a couple of questions about trauma, either to the neck or the face, so can trauma cause trigeminal neuralgia? That's a question I even had too. Or how does trauma, is that neuropathic facial pain?
Yeah. So, I think it depends. Right. I think it depends what happens and what, it depends is the one word answer. So, I think, say you're in a car accident, you get some whiplash, you never had trigeminal neuralgia before, and now you have it. Now, why did that happen? Well, you get your MRI and the vessel is on the nerve. The vessel didn't move. You were just kind of existing with this condition and something sent you over the edge. And we see that all the time where there's something happens and people come to seek medical care because they just were, vulnerable to that. And, then there's like trauma to the face or, directly to the trigeminal nerve. And so when there's trauma directly to that area, that tends to be the neuropathic pain.
Okay. And what if there doesn't seem to be any specific trigger for a flare? What if an attack seems to start randomly? What would that say to you in terms of diagnosis?
I'd like to know, so I think in that case, a pain diary would be very helpful because sometimes we don't know what that trigger is, and you can think about, okay, what else was going on that day? Is it something like, where it's not as obvious as the wind blowing, but I was under a lot of stress. Gosh, I didn't sleep. Gosh, I had my period. I had, the flu and was on antibiotics. Is it any of those things? And so recording that can be very helpful.
So really, any other factors that were going on when you notice that the pain comes on?
Yeah. But I wouldn't do that for everybody. I would do that in these tricky cases.
Okay. In terms of, we're going to do another Facebook Live about treatment, but I am getting several questions. So feel free if we need to put these off to next time. Do you recommend microvascular decompression for any of those types of diagnoses, any of those diagnoses that you gave, or only typical trigeminal neuralgia or atypical trigeminal neuralgia?
Yep. So, microvascular decompression is a good operation, and the most long-lasting operation for trigeminal neuralgia type 1. In a lot of cases, it can be used for trigeminal neuralgia type 2 as well. And the decision to go through with a big brain surgery has to be a big conversation between you and your doctor. For trigeminal neuropathic pain, deafferentation pain, I absolutely do not recommend it. And we're going to go into stimulation and other type things that we less commonly talk about in the trigeminal neuralgia world. And again, this is why the diagnosis is so important, because if I misdiagnose somebody with trigeminal neuropathic pain or deafferentation pain and then do a procedure, that's going to have a very bad outcome, and we want to avoid that at all costs.
Yeah. A couple of real quick questions about medication. I'll ask them both at the same time. One was, is there anything new kind of coming down the pike? And also, if someone is in pain and suffering and they've been taking the same medication, at what point, how long should they give a medication to work before they, call their doctor and try to put on something different or get a different dosage?
Yeah. So there's different medications that, have longer and shorter times to kick in. And so, a couple of so let's talk about Gabapentin, because, there can be some issues with this one in particular. It generally takes 3 or 4 weeks to see results. Every time you bump up the dose, it can take 3 or 4 weeks to see results. You have to take it around the clock. Sometimes people think it's like a pain medicine where, like with Motrin. I don't take Motrin around the clock, but I take it when I have a headache. And they're taking it intermittently and not taking it right. Then there's other cases where people have, tried kind of really teeny tiny doses of these medications. And so it's important to make sure that the dose is correct. Having said that, when I just said, oh, we're going to go up and we're going to wait 3 or 4 weeks, and then we're going to wait 3 or 4 weeks. I get it that you're in pain and I need to do something in the interim to help you relieve that pain. And so if, you're in this thing where you just, you can't deal with it anymore and you've given it the college try for a couple of months, you need to call your doctor.
Yeah. And with treatment, I'm assuming you talked about this a little bit. You said, is this affecting your eating? Is it affecting your sleeping? I would think that people coming to you need to be really clear about, I'm a pilot, or I'm a whatever it might be, that, they need to be clear with you, because that might change what you recommend for them. I mean, there might be some people who you might either, recommend surgery or not, or certain medication or not, based on their lifestyle and their career. Or
1,000%. I think, I think we spend so much time as doctors, especially when we're seeing a new patient. So, we didn't know each other. We're coming in. I want to, my first priority here is to kind of nail down the diagnosis so I can start your treatment plan. And so I don't find out until oftentimes time has passed that, oh my gosh, you're a pilot. I would have done this differently and other things. So if there are pertinent things about you that I need to understand, there's a long-lasting Gabapentin that I said, oh, this will be great. I'll prescribe this for somebody because it makes people sleepy and I'm going to try it at night. Well, little did I know that person had to take care of, a child at night or something else.
Right,
so I need to know those factors in terms of I mean to ask all the questions, but how, especially with pain, we can get talking about a variety of things, and I just don't understand, and it's a short amount of time to really get to know somebody.
Right. Well, thank you so much, Dr. Polizzis. This has been wonderful. Is it okay if we send you, if people have follow-up?
Oh, I would love that. Thank you very much. This was great.
And thank you so much. And again, we're going to post your contact information on this page. For everyone watching this, will also, the recording will also be put on the Facial Pain Association website, as well as our YouTube channel. And send me those apps.
Okay, I definitely will.
Okay. Thank you, everybody. Have a great night. Thank you, Dr. Polizzis.
Take care. Thanks so much.
Bye-bye.
Bye-bye.